Okay, great. Well, I just wanted to welcome everybody to come in tonight for this webinar. It's a kind of a new format for myself. I'm used to sort of the in-person presentation, so I'll do my best. I'm a bit animated, so to sit in front of a screen and run through it is a little different for me. But we'll do our best to address any questions that come in, and hopefully we can kind of go through this a little bit, do a little bit of education, and answer some questions people may have. So kind of the title of this is Shoulder Instability in the Athlete. And to give you a little background on myself, I'm an orthopedic surgeon. I've been in private practice for going on 21 years now. My first 19 years, I practiced in Eastern Pennsylvania, about an hour west of New York City, about 45 minutes north of Philadelphia, and decided about a year and a half ago with my family to try something different. And so I ended up in the Pacific Northwest, and I actually work at Washington Orthopaedic Center, and we have offices down in Olympia and then a little farther south as well. So I have a lot of experience coming out of a sports medicine fellowship at the University of Utah and taking care of athletes, really from everything from, little kids spraining their ankles up through professional athletes over the time that I was back in Pennsylvania. And we're going to talk a little bit about today, like I said, shoulder instability in the athlete, and a little bit kind of focusing on some of the problems that occur with shoulder instability. Thanks. We can start the next slide. So I always touch a little bit on just anatomy of a body part before we get into it. So the shoulder joint is the glenohumeral joint. So it's a ball and socket joint. It provides the primary source of motion for the shoulder. Now, a ball and a socket can be built a couple different ways. And in the shoulder, the analogy I like to give patients a lot of times is it's kind of like a golf ball sitting on a golf tee. And the socket, therefore, is very shallow. In the little picture you see there, which is a surgical dissection of obviously a cadaver, you see there's a big round ball, and then there's just a real shallow socket to the left-hand side. And what that does is it provides you a significant amount of mobility of that ball and socket joint. So that's different than your hip joint, which is a situation where the ball fits fully inside the socket. It's what we call constrained. And because of that, at least for most people that don't have a lot of loose joints, you see better mobility of your shoulder and less mobility of your hip. You're not generally putting your foot behind your head, whereas you see in a picture here, it's easy to put your hand behind your head. As a loose joint, or as a joint that doesn't have a lot of constraint to it, it makes it less stable. And so that's what ends up leading to problems, especially with certain athletic pursuits, though it can happen to anybody in any situation. Next slide. So I like to touch on two different things that are kind of important for shoulders. One is what we call static stability. So in static situation, if you click on that slide once, in the top right-hand picture there, that's a cross section through the shoulder. So imagine it again is like a golf ball sitting on a golf tee, but turned sideways. Now, the joint surface itself provides a little bit of concavity or a little bit of a socket, but there's also what we call the labrum, and that's what popped up in red there. And that's essentially like a rim around the edge of the socket. It's something you don't see on an x-ray because it's not made out of bone, but it's more stout than the capsule and the ligaments around the shoulder. So that provides a little bit more of a concave surface for the ball to fit into. Additionally, in the next picture down, we have what essentially is the capsule or the lining around the ball and the socket. And that's represented by those blue letters that you see. And generally speaking, in the shoulder, we don't have real discrete ligaments, which are like ropes that go to bone, from bone to bone. We have areas of the capsule that are thicker than others, but those are like tethers. If you imagine you tied a boat up to a dock and that boat rocked back and forth, you'd be limited by those ropes. And that's the way the capsule and the thickened parts of it work at the shoulder level. So those are the two areas that are your static stability. And then you have dynamic stability. And so that involves the musculature around the shoulder. And probably what's most important in the shoulder is the rotator cuff. And somebody came up with the idea one time to explain it as though that bottom picture, if you imagine the baseball is the top of the ball of the shoulder, okay, and your fingers are the rotator cuff muscles coming and attaching. And when you hold a baseball, you hold it against the palm of your hand, and the palm is the socket of the shoulder. But the way the rotator cuff works is those muscles can actually move and stretch. So they actively or dynamically hold the ball on the socket. Next slide. Now, I touched on the idea of the labrum before on that top image from the prior slide, but here's a straight-on view of what the socket of the shoulder looks like if you strip everything away. And what you see in the center there is basically the cartilage, the smooth surface of the base of the socket. And as you can see, it looks relatively flat. There's not a lot of depth to it. But what we have to add to that is that labrum, or that rim that you see around it, just next to where the tip of the surgical scissors are. Now that labrum provides both a bumper or a lip around the edge of the socket, making it deeper, but it's also the origin of that capsule and those ligaments that I mentioned earlier. So it's an important tethering point for providing stability in the shoulder. Also, if you look at the top of that picture, there's sort of a flat looking structure coming off the top of the labrum, and that's actually where the biceps attaches. And there's two attachments of the biceps in the shoulder. That's called the long head of the biceps. And that has some importance in one of the injuries we're going to talk about a little later. Next slide. Now, the most common sort of injury associated with instability in the shoulder is injury to what we call the anterior labrum. So that just means the front part of the shoulder, okay? Now, there's two ways that people generally damage that part of the labrum. The first, and especially the thing we see, again, most commonly in athletic injuries, contact sports, is the classic dislocation. So when people dislocate their shoulder, the ball pops out of the socket, sometimes just quickly and then pops back in again, or sometimes it pops out and stays out of the socket. Now, when that happens, you injure parts of the shoulder. You tear the labrum, so that's that bumper and that tethering point. And then if it comes out very violently or goes back in very violently, you can actually injure the bone of the shoulder as well. And then if you get old, like myself, it's common sometimes to damage the dynamic structure we mentioned earlier, which is the rotator cuff. So your muscles are less elastic as you get older, so they're less able to tolerate that much stretch. When you see a young patient who dislocates their shoulder, very, very unusual to have an associated injury to the rotator cuff at the same time. The other possibility of how it happens is what we call repetitive subluxation, or just a slipping. And that's where repetitive stress causes the ball to kind of gradually move back and forth. And that starts to gradually peel away the labrum or gradually damage the capsule of the shoulder. And we'll see that, say, in a swimmer, a volleyball athlete, somebody who's doing repetitive things with the joint. So you can have these non-contact injuries to the labrum as well. Next slide. Now, what do you do with a labral tear? Well, generally, this description here is kind of what we do with those traumatic injuries. So once the shoulder's back in joint, whether it goes back on its own or perhaps the patient has to go to the emergency room and get it put back into place, because essentially if it gets stuck out of joint, those muscles have to be relaxed to be able to pop it back in again. But once it's in, an x-ray's taken, as long as everything looks set, basically what we're going to do is we're going to look at a short-term amount of relative rest and a little bit of immobilization. Here in the US, we generally put people in a sling. In some countries overseas, they put patients in this type of a little external rotation brace. Predominantly, it came out of Japan, but the idea behind it was that maybe the tissues would heal a little better in that position. Unfortunately, it hasn't been shown to be a lot better, and those types of braces are pretty expensive, so we don't generally use them as much in the US. We'll keep a patient in that for about 7 to 10 days to let the soft tissue that has stretched kind of recover, and then we'll start working on what are called isometrics, and this is working with the physical therapist on getting the muscles firing, but without a lot of motion of the shoulder. So isometrics are kind of tensing the muscle, but not necessarily moving the joint. And then gradually working on range of motion. And with shoulder dislocations out of the front, we're trying to avoid things that involve lifting the elbow away from the body or put the, the hand essentially up and away from you like this, because that's a more unstable position. Next slide. Now, how do we move past that? Well, we've got to start working on strengthening those muscles. They've been stretched. So we mentioned the rotator cuff. That's very important. The second thing is actually strengthening the muscles around the shoulder blade. Something I didn't necessarily touch on earlier is that the socket of the shoulder is actually part of your shoulder blade. And so just like if you're trying to balance a ball on your hand, like in this picture, if my hand were constantly shifting from side to side, the ball would want to slide off of my hand easier. So if you don't have strong muscles holding the shoulder blade firmly in place, you're going to have a hard time controlling things, and it's going to be harder to rehab your shoulder. And that's why not just doing rotator cuff exercises, but strengthening the muscles around it is very important. Almost always, these patients are going to physical therapy, minimum of 4 to 6 weeks. And then as they're getting better, for an athlete, we have to decide, can we release them to activities in the short term or the long term? And do we need to put them in a brace to protect that shoulder for a little while? And there are some different types of braces and different sports that we might use them in. Now, the one thing I counsel every patient about who has these types of injuries is if they fall into 2 areas. One area being they're young and athletic, meaning they're going back to a contact sport or a high energy sport, and this injury happened with trauma. They have a very high recurrence rate, usually better than 85%. They're going to dislocate their shoulder again if they go back and do those activities. Or in an older patient who has a large rotator cuff tear that happened at the same time. Those 2 subpopulations, sometimes we're going to lean on, hey, you may need surgery even though you're starting to feel better before you have another problem happen again. Next slide. So how do we look at these things? I mentioned earlier, we get an x-ray. We mainly do that to make sure that that socket, the glenoid, didn't fracture. If you think about my golf tee example from earlier, if the top of the golf tee is broken, if we have golfers out there and I'm not one of them, the ball falls off the top of the golf tee easier. And so if there's a fracture in the edge of the socket, that needs to be addressed differently. Typically, the next level of imaging is obviously getting an MRI. We usually will do what's called an arthrogram, which involves injecting dye into the shoulder joint. This is just a fluoroscopic picture here showing the needle, which is the straight line, and the white little cloud that you're seeing at the tip of it is they're starting to inject some dye into the shoulder joint to confirm it's in the joint. Once that's done, they'll take that needle out and then do the MRI. Next slide. So this is kind of what you end up seeing. This is the example of that golf ball sitting on the golf tee, what we call an axial image or a cross section of the shoulder. So on the top picture, there's a round ball. There's a shallow socket at the bottom. The white that you see is dye that was injected into the joint. And where that little arrow is going, you can see a faint white line going underneath the edge of that ridge or that edge, and that's actually the labrum. So they're small things. They don't look huge on an MRI, but that's a classic tear of the labrum. Now, in the bottom picture, and this is where we say we want to look at the MRI images ourselves as orthopedic surgeons. That small arrow is pointing to something that was read as maybe a tear of the labrum. But what that actually is that's a thickened part of the capsule of the shoulder. So basically, when I look at something like this, I have to look at multiple images in different planes or cross sections to definitely determine whether it's truly a labral injury or not. Next slide. Now, sometimes we do specialized images, and this is just a funny one. It's called an ABER image. It's called abduction external rotation. It just means they put the arm over the person's head while they're in the MRI machine. And what that does is it pulls things tight in the front of the shoulder. So on the left-hand side, between those 2 yellow arrows, that's the capsule or the lining of the shoulder joint. going up and attaching to the labrum right at the edge of the socket. So it essentially pulls things tight. When you look in the top right, that black arrow is showing you in the same type of an image what happens if there's a tear. You see there's a gap and you see a little white amount of dye going in there. So that's a small tear of the labrum. In the bottom, you'll see a bigger fissure, a big white line in the same area. And that's somebody who's had multiple dislocations to the point that the labrum is stripped off the front of the glenoid of the socket, and there's a lot more dye going down there. And the socket itself doesn't even quite look cup-shaped anymore. It looks flat in that area, and that's a big problem for patients when that occurs. Next slide. So what do we do generally to fix this? Well, the gold standard generally over the last 20 years has been to treat these things arthroscopically, as long as there's not secondary injuries. It has good outcomes, and what I mean by that is recurrence rate is 5 to 7% with doing arthroscopic repairs, meaning the chance of it popping out again in the future. So you go from 85% chance to 5 to 7% chance. That's very similar to what was accomplished with open procedures, but because we do it arthroscopically, we spare damage to the rotator cuff to get into the shoulder, and we have a better chance of recovering normal motion. So years ago, when people had open shoulder surgery, the shoulder may not pop out again, but they would have a difficult time with motion, lifting their arm. And that was just accepted what you would get out of this surgery. Now we can fix a labrum, have it stable, and that patient can come back in and put both their arms over their head equally. Next slide. So when we do shoulder arthroscopy, it's an outpatient procedure. You come in and go home the same day. It's done with a combination of anesthesia. The patient's asleep. They get a nerve block to numb up the shoulder. And essentially, we'll do this through a series of small holes in the shoulder. This is a view looking down at the top of a right shoulder. To the right-hand side is the front of the body. You can see the elbow down below and the forearm. And so where those little marks are, where A is generally where we put the camera in. Where B is where we do work in the front of the shoulder, and C is like an accessory portal if we need it. So those are different ways to essentially look inside. Now, as the instruments and the anchors have become smaller, they've also become better. So now we use very little metal in the shoulder. We use absorbable anchors. We use things that will allow us to do MRIs in the future, or if somebody re-injures their shoulder, we don't have sort of metal in the way of doing secondary procedures. We do this with fluid insufflated into the joint, which pushes apart the ball and socket a little bit to allow us to put instruments in there a little bit easier. Next picture. So this is just a quick picture of what you see when you look into the shoulder. So this is a right shoulder. We're looking from the back to the front. In the lower left-hand side, that's actually the top of the ball of the shoulder, that slight little curve you see. The yellow arrow is pointing to the top edge of the front part of your rotator cuff called your subscapularis. The socket is on our right-hand side, just out of view where the blue arrow is pointing. And the red arrow is pointing to that long head of the biceps, which I told you comes in and attaches to the top of the labrum. And that sort of creates a little triangle area called the rotator interval. And that's where we'll put instruments into the shoulder and not worry about damaging those structures that are around it. Next slide. We look around the shoulder. What else do we see? On the left-hand side, we're looking at the top part of the rotator cuff, sort of the roof, as it's coming in and attaching to the top of the ball of the shoulder. That's your supraspinatus, that thin, straight structure just underneath the metal probe there. That's the biceps coming up into the shoulder. And then on the right picture, we're actually looking underneath the ball, so below the ball in the socket, at that capsule or lining of the shoulder joint, to make sure there's no tears, no pieces of cartilage floating around down there that can happen when you dislocate your shoulder. Next slide. Here's another picture of the top of the socket. So see how shallow that socket is, and the shaver device that's in there right now is just beneath where the biceps is attaching to that labrum. Next slide. So here's just a quick picture of what a tear would look like. So we're looking from back to the front. The socket is on the right-hand side. Those red arrows are looking at sort of the crevice or the line where the labrum is separated from the edge of the socket. So that little metal probe is looking at a little frayed piece of the labrum, and then the labrum is separated off where those red lines are. And so when we're fixing it, we're going to go in, and in the right picture, we have an instrument where we're passing it underneath that labrum tissue, and that allows us to put sutures around that area. Next slide. And this is just some pictures. Sutures going in, sutures pulling on the labrum. This was a very damaged labrum where you can actually see the edge of the socket has some cartilage damage to it. And then we're putting some anchors in. Those anchors are knotless anchors. They're work kind of like a drywall screw. They fit into the bone. They sort of lock in place, and very low profile. And your body actually grows into them. So the bone actually integrates into them over a series of time. Next slide. And this is just a quick picture of what a labrum would look like after it's repaired. So on the left-hand side of your screen, that's the front of the socket. You can just barely see the white of the suture there. The anchors are fully in the bone, so you don't see any knots. You just see the anchors there. And I tell patients what we're trying to do is we're trying to recreate that sort of bumper effect. So like create a ridge where the labrum's reattached, but that also tightens up the ligaments that are attached to it, and helps restore the stability of the shoulder. So think of it like kind of spot welding the labrum back in place. Next slide. Now, let's flip around to the other side of things. So one of the other ways you can hurt your shoulder, it can be a situation where you damage the back of the shoulder. So the most common, like I said, is the front. But one thing we see in some very specific athletic injuries are damages to the back of the shoulder. I see this in football players two ways. One is they fall down, or really any sport, they fall down with their hand out in front of them and they push their arm backwards. So it gets pushed back really violently all at once. And that's obviously how you're going to damage the back part of the labrum as opposed to the front. And the second thing is people who lift a lot, okay? And it's not that lifting's bad, it's just how you do it and how much stress you're putting on your shoulder. So somebody who's doing lots and lots of bench press activities, poor position perhaps, not having other muscles strong, that's going to slide that ball backwards on the socket, and you're going to get a gradual tear. Okay. And again, sometimes sports like football, where you're blocking somebody and you're constantly hitting them, or you're doing that in practice, that can cause it as well. Unlike dislocations in the front, it's really hard to actually pop the ball out of the back of the shoulder because of how big the musculature is in the back of your shoulder. So very, very difficult. Rarely see that. It's things like where people have seizures or have electric shock injuries, things like that. Next slide. So when we examine these patients, we look at them a little differently. First, we want to see, how does their shoulder blade look? So if it's somebody who's been doing a lot of blocking activity or weightlifting, these things happen gradually. And what starts to happen is their shoulder blade starts moving abnormally. Back to that thing I mentioned before, your body's trying to move the shoulder blade to help keep the ball sitting on top of the socket. So it's actually learning bad habits to try to help it feel better. Second thing we want to see is a lot of these patients will simply lift their arm and you can see it clunk. You can see it literally shift as they lift their arm. And then the last thing is we do tests. I always love dictating that I'm doing a jerk test on somebody. It's like nothing personal to them, but it's basically just pushing on the elbow, pushing it backwards, and then bringing the elbow away from the body and feeling it kind of pop back into place. Oftentimes it's just painful, but sometimes you can actually feel it move and shift quite dramatically. Next slide. So same thing, we're going to get an MRI here. Same thing with dye. In this image, the arrow is actually pointing to the back of the shoulder. And just like in the front, you can see how that white dye goes very clearly underneath that labrum. We also, in the posterior dislocations, want to see, is it wearing the socket down? So is the cup of the socket becoming flatter in the back? Because that's a bad problem. And also, are there any loose pieces floating around? Next slide. So how do I manage these patients? Well, if it's not a super traumatic injury, the first thing I do is I say, what do you do? Like, what activities are you doing and how do they bother you? And so it's a lot of counseling for like weightlifting and things like that, which I've kind of had to learn over the years a little bit. I was a swimmer, swam in college, clearly not somebody who was trying to like push around massive weights. And what you have to understand is arm position, incline, flat, how wide your hands are, going from a flat a flat bar to dumbbells can really make a big difference. So some of these patients, they don't always need surgery. If we modify what they do and we teach them how not to aggravate their problem, I tell patients all the time, labral tears, it's not a blocked artery in your heart. So we can try to do things short of going to surgery. Secondly, we always work on those rotator cuff exercises, again, to help hold the ball better on the socket. And then in some sports, if we've got somebody during a season who's having a lot of pain, a lot of difficulty, and we're trying to get them through a season, it's their senior year, they're getting recruited, that whatever, they're trying to get into the NFL, you'll see even NFL players playing with braces that you can see, it looks like a cuff on their upper arm, and that's actually hooked to their shoulder pads, kind of like this brace you're seeing here. And it limits kind of how high you can get your elbow away from your body. And when your elbow's lower, it's harder to shift the ball back and forth. Next slide. Now, two things that we have to be careful with when we're looking at those MRIs. I mentioned them a little bit earlier, but essentially, if we start to see situations where the cup is not as deep anymore. So the top image is a posterior labral tear, but if you look at the socket, it's still cupped. If you look at the next one down, it's flatter. And then if you look at the bottom one, it's almost completely sloped backwards. And the bottom one's a CAT scan. That's why it looks a little different, but it's showing us the bony anatomy there. So the less of a cup you have from a bony standpoint, you're going to have problems keeping the ball on the socket. And that's important to understand. You have to look at these things ahead of time to counsel the patient about what our success rates are with non-operatively managing them versus do we need to think about a surgical treatment. Next slide. Also, even when you think surgery is going to be the best things, there's certain contraindications. And this is important. I know we've got a lot of people, on these webinars, and everybody's all different ages. So I know I'm not just talking to people that are, 24 years old and trying to play football. But if you have a labral tear, but you're to the point where the cartilage is worn down, so that top picture is a CAT scan of the shoulder, and it looks like the ball and the socket are literally kissing each other. They're right on each other. That person doesn't have any cartilage left, okay? Their labrum is not going to look good on an MRI. They might have all these symptoms, but if we go in and fix their labrum, we're going to make that person miserable. They're probably going to hurt more, or they're definitely not going to feel any better. So that's a whole nother situation. And then in the bottom left, it's a reverse of the other images that we've been seeing. So the ball's on the left-hand side, but that's where those little dotted triangles are. That's showing you how much slope they have to their socket compared to the little dots, which is where it should be. So that's a situation, somebody who's actually born with something called glenoid dysplasia or flattening of the socket. And as a result, that person's labrum is just never going to be normal. Even if we fix that patient has to understand they're not going to have a normal shoulder. So those are situations we have to really pay attention to as surgeons in counseling them. Next slide. So just a quick picture. This is a reverse of what you saw before. This is looking from the front to the back of the shoulder. That little metal there is actually just the tip of a needle. That's how small it is. And where the arrow is actually the edge of where the labrum attaches to the bone. Next slide. So same thing. We come in from the back of the shoulder, and we're actually putting a little what we call a suture passer underneath the labrum. And actually the little pink area you see next to the labrum, that's actually a little bit of that capsule. So we're actually doing like a tuck procedure where we're putting suture through the labrum, but also pulling up a little bit, almost like if I went to the tailor and we wanted to pull the fabric over a little bit to make it tighter. So we put that in, and we can tie that down and actually pull the tissue tighter in the back of the shoulder. Next slide. The recovery for something like this, we typically will immobilize them for about 6 weeks with a sling. But this time we do use that pillow, because what we're trying to do is avoid, if we keep the hand out in front of them, then if their hand isn't drifting in, they're not pulling on what we fixed in the back of the shoulder. So those patients will be in this sort of abduction orthosis. And we'll avoid doing really anything stretching wise for the first 6 weeks. And I tell them you're not going to be doing any of your bench press activities for a minimum of 6 months. And that's pretty much contact sports as well, if not longer. Next slide. Now, the last one we're going to touch on is a little bit of a controversial area, but I'm not going to go into the controversy of it. But a lot of people have heard of what's called a slap tear. And what a slap tear stands for is very simply superior labrum anterior to posterior. Next slide. So this is a busy slide, but just imagine that thing that looks like a pear in the middle, that's the socket of the shoulder if we took the ball out of the way. And that little gray rim around the edge of it represents the labrum. And where the red circle is, that's where a slap tear happens. So it's the top of the labrum, the superior part, and from anterior to posterior, from front to back. But what's important here, and this goes back to one of my early slides, what do you see attached there? You see it says biceps. So the biceps, long head of the biceps, attaches to the superior labrum. So injuries in that area for athletes with problems is related to repetitive use and micro instability of the shoulder. So this was first described by Steve Snyder in Southern California in baseball players. And that's where slap tears originated. The idea of them came from. New slide. So he described what was called peel back. And it just meant that when your arm kept throwing a lot and you kept putting your arm back here and further, and if you've ever seen pictures of throwers, sometimes their hand is way back here when they're throwing. Every time you rotate back, the biceps pulls on the top. So this is a sideways picture of your shoulder here, but on the left-hand side, the biceps is sticking straight up from the top of the socket. And then when you look at this arthroscopically, you can put the arm in that position up and out, and where that circle is on the right-hand side, that's showing the labrum actually peeling away where that fraying is. So this was a thrower who was having pain, having issues, and led to surgery, and this is what that peel back looks like. New slide. Now, these athletes and people with problems present very differently. It's usually a vague onset. It's usually not an acute injury. Because it happened in throwers, we always ask them, if they're a throwing athlete, when does it happen? It usually doesn't start right away. It's as they start to throw. So it doesn't happen on their first 10 pitches, but it gets worse by their 30th or 40th pitch. They oftentimes come in saying, I'm just losing velocity. I can't throw as hard as I used to. And then we ask them where it happened. Because again, if it's up in what we call the late cocking phase, which is when you're way up here, that's one of the most common positions that gives an issue. Again, when we examine them, the first thing with these throwers, we're going to look at how their shoulder blade sits. A lot of times it's been painful for so long, they walk in and one shoulder blade's kind of down and forward because that feels better for them. So we have to see how their shoulder blade sits. We also want to see how much motion they've lost. So because this problem happens when their arm is up and out, as a result, they oftentimes lose their ability to follow through on their pitches, to let go of things. And that puts more stress on their shoulder. We don't feel like we can pop them out of place on examination. And then their pain, go to the next slide. Their pain is oftentimes, if you lay them flat like this and you put their arm all the way up and out, it actually hurts in the back of their shoulder, which is very different than other problems like anterior labral tears. Next slide. There are tests out there. This is a little busy. Suffice it to say, we'll try some of these tests, but in my experience, 20 years of doing this, and the guys I know that are really taking care of some of the major league guys on a regular basis, it's never 100%. I'd say 50-50 at best that you're going to find positive findings on this. Next slide. So what do we do? Obviously, we go back to our imaging. X-rays are normal. We will always get an X-ray to make sure there's nothing funny shape or a way that, like I said, that socket didn't form normally. But the main thing is we're going to do that arthrogram. That'll allow us to look at the labrum. The one difference with throwers is they will sometimes have a partial tear of their rotator cuff. So that image that you see here is a front view of a left shoulder. That gray structure in the middle is the top of the ball of the shoulder. The socket is to the left-hand side. And where that circle occurs is where that top part of the rotator cuff is coming over like an arc. And if you look, the dye looks like it goes up into it. And that it should be nice and smooth there. So the white kind of sticks up into that area. So that's a partial tear of the rotator cuff. We also will look for what are called paralabral cysts. They're not a cancerous thing. They're nothing like that. They're literally where fluid from inside the joint has gradually leaked out underneath where the labrum has torn. And we see this a little more commonly in these slap tears than in other problems because they build up gradually. New paragraph, or sorry, next slide. Here's just a front view of an MRI to show you the difference on the left. That's what the labrum looks like in a normal shoulder. On the right-hand side, that white goes up underneath that little triangular structure. So that's what a slap tear will look like on an MRI. Next slide. Arthroscopically, this is looking at a left shoulder from the back to the front. The top left image is a normal biceps and a normal labrum. And then the next one over, if you click on the slide one time, so that's normal. Where the circle is there, that's actually something called a sublabral foramen. We're not going to have a test on that later, but that's a normal finding. Some people have that. That's just a hole in the labrum. But if you look at the top right one, when we put an instrument in, that same shoulder as the middle picture, we can actually push that instrument underneath the labrum, and there's a little tiny reddish color right at the tip there. That's actually fluid from a cyst that we're basically evacuating from underneath where the labrum's torn in that picture. Next slide. So treatment of this, it was described in 4 phases. There's a very famous physical therapist by the name of Kevin Wilk who worked very closely with Jimmy Andrews and some of the guys that are taking care of a lot of the major league athletes for their throwing problems. And he described 4 phases of treating this. The first was reduce pain and inflammation. So icing, anti-inflammatories, and these guys are not throwing for 2 or 3 weeks right out of the gate. If they're doing well and they don't have a traumatic injury, they start working on a progressive strengthening program. We talked about losing that ability to throw all the way down. So they work a lot on stretching their posterior capsule, the back of the shoulder, and try to make that arc of motion. If you look at me sideways, from up here at 90 degrees down to 90 degrees, you should have a good arc of motion of 160, 170, 180 degrees. And so these athletes oftentimes lose that internal rotation. So they have to stretch to get that back. Then you work into advanced strengthening, what we call the kinetic chain, which means we're going to strengthen the shoulder, the therapists are, but it's also going to involve strength around the elbow, strengthen the upper back, strengthen your core, strengthen your hip, because all of those things need to work well in a throwing athlete. And then if all of that is strong, then they start throwing again. Next slide. So the last choice in these throwing athletes, again, not with the traumatic injuries, we're talking about these slap tears, is to go to surgery. Because if they have any loss of their motion that they have naturally, they don't throw well afterwards. So James Andrews, who's kind of he's down in Birmingham, Alabama, he's probably, kind of not really operating anymore. He's been around so long. He'll tell you, and he's done more pro athletes, more throwers than anybody, once you operate on them, it's 50-50, especially if they're a pitcher, that they may not be able to make it back to their major league level anymore, even if you fix them, because just little changes in what their God-given flexibility, 5 or 10 degrees, you may fix their labrum, but they can't throw like they did before. So that's always the last choice in a thrower, is to go to surgery. If they do have rotator cuff involvement, we will sometimes do rotator cuff surgery on them, but only if it's a partial tear that's significant, more than 50% of the thickness of the tendon, for the same reason. Because one of the biggest side effects, you fix a rotator cuff, patients lose a little mobility. Their pain may get better, their strength may get better, but their motion isn't quite what it was before their injury occurred. Next paragraph. So in looking at slap lesions, there's a lot of classifications. I don't want to belabor it, but essentially, I bring this up because of the controversy about slap tears in general. So a lot of MRIs will be read as slap tears. And it's very important if you're seeing a physician or seeing somebody and talking about this, that you understand what kind of complaints a patient has. What's been learned over the years as people got very aggressive with treating these things based on MRI findings is we've now learned that abnormal findings on an MRI are oftentimes a normal part of aging with regards to your shoulder. So if you see somebody, I'm basically at that mid-50s age now. If I have a slap tear on my MRI, I really shouldn't be going and getting that fixed most of the time because it's what we call a type 1 slap tear, which basically just means it's starting to get frayed because I've been using my shoulder my whole life. And I don't need to go in and tighten it up because the issue is it just might be a little irritated. And if I've got another issue going on in my shoulder, we clean it up with a shaver, just like we clean up a little cartilage issue in the knee, but we don't go through fixing them. Next picture. The difference is the type 2 tears, those are the ones that peel back. In this picture on the right, that's where you see the frayed area. And that represents, again, instability where the biceps attaches. We oftentimes see the cysts and primary repair in the throwing athlete who's failed conservative management is to go in and repair them. Next slide. So here's a picture. Again, we're looking at a shoulder. The socket's on the right-hand side. We have a probe up underneath where the labrum is torn. We're seeing if there's a cyst there that we can clear out fluid there and to prepare the edge of that socket by cleaning it up a little bit to reattach it. Next picture. And here's a picture. We're basically putting another instrument in to pass sutures around. So you can see it coming underneath the labrum, just behind where the biceps is coming in. And what we're trying to do is we're trying to compress that labrum back on tightly and let it heal. So all of these ways of fixing it, I mentioned the idea of spot welding. We're basically pinching it on tight at certain spots and then letting the body heal. So analogous to you've got a cut in your skin, we're going to put stitches at intervals to hold it together, and your body's going to take over from a biologic standpoint to let it heal. So we want to anchor it sort of at the length of the tear itself, at the front, middle if needed, and back. Next picture. These are sutures going through where we've just seen that instrument going. And then the next picture is kind of what it looks like once we've tied those sutures down. It's held down very tightly. That little plastic circle that you see is what we call a cannula. And that just allows us to put instruments in and out of the shoulder once we pick the spot, so we're not constantly poking through the tissue itself. So it's like a tube. Next picture. And this is flipping around. We're looking at the other end of the tear. So as the labrum goes around the back, the tear went a little farther down. So what we've done here is a final repair. You see a series of positions here at like sort of, think of it like a clock face. So you've got, 12 o'clock, 2 o'clock, 4 o'clock. Anyway, you're going to put these little anchors in to hold that labrum back to let it heal. Next slide. Now, what do we do from a postoperative protocol standpoint for these patients? It's very similar to what you've done for other ones. We're going to immobilize them generally for their day-to-day activities so they don't put too much stress on their shoulders. It says 3 weeks minimum. I'm generally a 6-week person with the sling, but some people will do 3 weeks if they like the repair because this is not an instability problem, so we're not worried about that ball falling off of the joint. You work on some external rotation early because you don't want to lose mobility, and moving your hand away with your elbow at your side doesn't put much stress on that area, and you get the elbow moving right away as well. And then gradually work into shoulder range of motion after 6 weeks. Next slide. As you get a little farther down the line, you're going to work on those problems you might have identified early on, stretching the shoulder, making sure that you have that internal rotation. This little sort of archaic looking picture, nice black and white and grainy, is somebody doing what we call a sleeper stretch, where you lay on the affected shoulder. That holds the shoulder blade in place. And then essentially you push down on your wrist. And that's a way to stretch the back of your shoulder solo. You don't need somebody else doing it for you. And it's rare to get your hand all the way down to the ground. It's sort of like you push on it, you count to 10, and then you release it. And then these, same thing as before, you have to re-educate all these other muscles. So we're going to work on rotator cuff, stabilizing the muscles or the scapula stabilizers, getting them strong again, and not doing any throwing or tossing till 4 months out. So the true slap repair, that's generally a season-ending injury. Next slide. So, in summary, in talking about this, there's a lot of different variations with regards to how shoulder instability can present. And I know I talked a little bit about focusing on labrum issues. Probably the number one thing, and obviously I have a bias with regards to being a surgeon, but the most important thing to understand is like, unless you're somebody who, again, had a traumatic dislocation right away, had a bony injury or a large rotator cuff tear, you're really going to be focusing on a rehab program for any of these problems, okay? So that's going to be your first step. It's not going to be a surgical treatment right away. And the second take home, again, for people who've kind of probably been told things, a lot of times, you may get an MRI done and your primary care doc comes and kind of says, well, hey, listen, we called you with the results. Don't freak out if you're told you have a slap tear, okay? And again, if you're my age, definitely don't freak out about a slap tear, because a lot of times that's a normal, you hate using the word old problem or degenerative problem, but that's something that it's going to be unlikely that we're going to go in there with the idea that you need surgery soon, and probably don't need surgery at all for it. It's really more about strengthening and rehabbing the shoulder afterwards. So not sure if we end up with questions from this. Feel free if you type them in. They'll usually kind of organize them for me if anything pops up. I appreciate everybody taking their time and do it, but I enjoy doing this with everybody. Yeah, no. That's it. I love the wrestling question. Okay. So I mentioned where I was before. So I was in Eastern Pennsylvania, and for people who wrestle a lot, hotbed of wrestling out there. A lot of the Division I kids you see kind of come out of, not all of them, but a lot of them come out of Eastern Pennsylvania, New Jersey. So a couple of things to talk about there. You mentioned asymptomatic, now flaring up. What I would tell you, generally speaking, is assuming that you were told you had tears of your labrum a certain number of years ago, but generally they weren't issues, but now you're starting to have shoulder pain or shoulder problems, you may be getting into the situation that I mentioned with regards to some arthritis issues. So if you've had a little bit of instability, the ball's been moving around a little more, not enough that it's popping out, you may have been sort of gradually wearing down the cartilage, and now you're starting to get situations where either the cartilage is rough in some areas, that might be causing pain. If you have high or low areas, you can get clicking and popping. So oh, now you're typing in a little more. Sorry, no arthritis, but Bankart lesions, loss of range of motion. Yeah, I think, again, a lot of that depends. Bankart lesions are situations where the front of the shoulder, that's a older terminology for injuries to the labrum in the front. It depends, again, if it's just a Bankart that's an all soft tissue lesion versus a Bankart lesion that's soft tissue and a little bit of bone. Again, you'll tend to get problems, even if it's not where of the cartilage, where the soft tissues themselves will start to become a little bit tight as well. And that compresses the joint more and oftentimes aggravates the symptoms. If you don't have any arthritis, if you really don't have any cartilage wear, your best friend is generally just working on stretching the capsule, working on a PT program to try to restore range of motion is oftentimes the best thing to do. What I'll typically do is I'll occasionally inject the joint with a little bit of a corticosteroid, almost as more of a diagnostic step. If we make you feel a lot better with a single injection into the joint, okay, that tells me that even though an x-ray may not show that the cartilage is worn, you may have cartilage wear that's more subtle than an x-ray would show, or even sometimes an MRI.